Good afternoon. My name is Bob Twillman. I'm the Deputy Executive Director and Director of Policy and Advocacy for the American Academy of Pain Management. I'm also a Clinical Associate Professor of Psychiatry at the University of Kansas Medical Center, where I practiced as a clinical psychologist for 20 years before taking my current job. And while there, I started and ran the acute pain consult service in the hospital and also helped co-found the palliative care service. So I'm going to talk a little bit about some of the workforce issues that we encounter with respect to treating pain. Because, treating pain, especially in its chronic varieties, is an enormously complex enterprise. Understanding anyone's total pain experience requires we attend to its biological, psychological, social, cultural, and spiritual contributors. And beyond understanding chronic pain, these same considerations have to come into play if we're going to be providing the best possible treatment for pain. Doing that, considering all of those things and putting them into play in treatment, is at the heart of the integrative model of pain care that's promoted by the American Academy of Pain Management and also by the PAINS initiative that we've talked about earlier today. It's also, as it happens, a very well-known and widely practiced approach in the closely related specialty of palliative care. Dr. Webster alluded to some of the challenges inherent in implementing this approach in today's healthcare environment in talking about reimbursement issues. Reimbursement is certainly an important impediment, preventing us from fully realizing the benefits of an integrative approach. Because where I think the current reimbursement models lead us, in the best of all situations, is not to an integrative model, but to an interdisciplinary model. And that's an important distinction that I want to spend just a couple of moments talking about. Interdisciplinary models require nothing more than the involvement of clinicians from a variety of backgrounds caring for a person with pain. All of those interacting with each other indirectly by communicating with a central communication hub. Many people receiving general medical care in our current system receive interdisciplinary care in that they may see a primary care provider who refers them to and gathers information from any number of medical specialists and allied health professionals such as physical and occupational therapists, nurse clinicians, dietitians, and even the occasional psychologist. While the advent of electronic health records is giving us more of an opportunity for these clinicians to communicate with each other, for the most part, the prevailing model of care is one in which the primary care provider is the hub in a hub-and-spoke system. That provider is responsible for developing and modifying the overall care plan with contributions from the other clinicians and then communicating that plan to the patient. Rarely do the other clinicians communicate with each other, and essentially what we have is a provider-centric model. An integrative model of care, on the other hand, emphasizes the frequent, extensive, and ongoing communication among all members of the care team. In the best of these models, the entire team sits down together and discusses the person for whom it is caring. Hospice and palliative care teams frequently engage in this discipline, and I'm sure that others who have participated in these discussions will agree that they provide a much richer and more complete picture of the person. This enhanced sense of the person's state of being contributes greatly to providing optimal care and achieving optimal outcomes, and is especially important with conditions that are best approached with a biopsychosocial spiritual model such as chronic pain. This is a person-centric model. I like to use analogies to explain complex concepts, and I think perhaps the best one for this distinction between interdisciplinary and integrative care is this. Imagine you wanted to bake a cake. In an interdisciplinary model, you'd open your box of cake mix, dump the contents into a cake pan, add water, eggs, and oil, and bake it. In an integrative model, you put all of these ingredients together in a mixing bowl, blend them together, and then bake it. It's a little bit of a distinction there. You're much likely to like the second product, I think. Our current reimbursement system doesn't make it easy for us to create the optimal person-centered team using an integrative model of pain care as I've outlined it. Beyond that, though, we also have to be aware that we lack an adequate supply of healthcare providers to provide all the types of care needed to treat chronic pain, and that the providers we do have often lack adequate training in using an integrative approach. I find the trend toward interprofessional training in our professional schools encouraging, and I hope it breaks down the guild-based barriers that have been erected over the last century or so. But what do we need to do to ensure an adequate supply of non-physician providers? As a psychologist, I'm acutely aware of how few of our graduate students are trained in caring for people with chronic pain. and how hard it is to find active clinicians who are truly competent to provide the highest quality pain care. I have to wonder, as the average age of our population and the prevalence of chronic pain increase in parallel, where we'll find enough physical therapists, massage therapists, acupuncturists, chiropractors, and others as we try to meet the demand. Certainly, adequate reimbursement for care should incentivize more clinicians to focus on chronic pain as a career emphasis. The burgeoning movement toward paying providers for good outcomes, that is, for doing the right thing rather than just for doing something, and then paying even more if you have to repeat that something because it was ineffective, also should support workforce expansion. But I think we need to ask if there might be a role for government agencies such as HRSA and CMS in supporting efforts to increase the integrative pain care workforce. And as we wait for new trainees to enter clinical practice, what steps can we take now to improve access to pain care experts through telehealth technologies and other methods? So as we consider all the things we need to do in order to meet our moral and ethical obligations to provide optimal pain care, let's not lose sight of the fact that we need to have an adequate number of well-trained clinicians who value an integrative approach. After all, we know it takes a team to provide good pain care, and while we expect people with pain to be part of the team, we can't expect them to be the team. Thank you.